Hey, Karam, can you unmic or unmute, please?
Have we been muted the whole time?
Yes. Sorry, I thought we were just hanging out.
Introductions, but I just wanted to throw a quick thank you to Kim Templeton for being here. She's very, very active on a national level, especially with diversity in orthopedics. Wanted to thank Adam Goodyear. Adam is a recent.
I wish
you're 1 year ahead of me,
yeah.
so we'll make you go okay. Who finished his residency here at KU and is practicing in the community. He's also the current president of the Kansas Orthopedic Society. And we have Rob Winfield here as well, one of our general surgery trauma surgeons who is very involved in community outreach. And so we thank you very much. I know it's not a general surgery event, but we knew your experience here would be fantastic to share as far as being out in the community and doing things beyond your own practice and whether it's orthopedics or wherever you go into. So I want to thank everybody for coming.
So we're just going to start off by allowing the host to kind of introduce themselves and what they do and kind of explain what their practice is. So whoever wants to start.
I can go first. As Dr. Sweeney was saying, so I graduated from KU Orthopedics here in 2015, which seems like just yesterday, but it turns out it's actually been at least 5 years ago. So that's wild. And I'd like to say hi to Dr. Templeton. I haven't seen you in a few years, but it's great to see you. I actually was born and raised in Kansas, and then made the trip down to Dallas and spent some time down in Texas, and then back up to Oklahoma for undergrad. So obviously I've had kind of a wild week with Lincoln Riley leaving and everything. So, then went down to University of Texas at Houston for med school, and then made it back up here. And I met my wife right before I started residency, and she was from Kansas City, so I knew I'd be around the area. And so then I did an adult reconstruction fellowship in Colorado and Denver, and then came back, and now I work with the guys and gals in Lawrence at Ortho Kansas. So my practice consists primarily of adult reconstruction, so hip and knee replacements, revisions of that. I'll do a little general stuff when I'm on call and things like that, but mainly adult reconstruction. I very much appreciate being here. One of the things that I'd like to say is I'm happy to see how many people that we have, because orthopedics is a fantastic career, and we don't have enough orthopedic surgeons, and it's going to continue to be that way, and there's more and more people needing orthopedics, so it's good to see a lot of folks like yourself interested in it. So I'm married. I have a little girl named Lucy, and then I have a golden retriever and a cat named Penny, and our golden retriever's named Dolly. So anyways, that's a little bit about me. So I'll pass it to the next one.
Maybe Dr. Templeton next.
Yeah. Dr. Templeton, you want to introduce yourself?
Hi, I'm Kim Templeton. Hearing that Dr. Goodyear has graduated 5 years ago doesn't make me feel as old as when I saw a patient last week who's a granddaughter of a patient that I've taken care of. That will make you feel old. So I grew up in the Midwest. I trained in Chicago and Boston, and then came back to the Midwest here at KU to practice. I specialize in oncology. Advocacy, I'm thrilled that we're talking about that, because that is a major chunk of what I do and what I've spent my career on from a variety of levels that I think we'll be talking about later. So my practice consists of primarily oncology. I also have a special interest in women's health, and especially women's musculoskeletal health. And so that is another component of my practice. I'm also the residency program director, and that takes up a fair chunk of time, as do the local, state, and national advocacy and other projects in which I've been engaged. So thank you for the opportunity, and I am thrilled to see the Adler Society in such great hands and see it moving forward and doing so well.
So I'm Rob Winfield. I promise I won't try to poach anybody from orthopedics and pursue general and trauma surgery tonight. except maybe orthopedic trauma. So I'm the chief of the division of acute care surgery, trauma, and surgical critical care. I direct trauma research here at KU as well. Some background, I am an Illinois native. I was born in Granite City, Illinois. But when I was 6, my family moved to Naples, Florida, and so I grew up in Naples, Florida. I came back, I went to the University of Illinois. I did med school at Southern Illinois University, then went back to Florida to do residency at the University of Florida. I did a 2-year research fellowship through the National Cancer Institute before moving on to do a trauma and critical care fellowship at UC San Diego. I joined the faculty in WashU. After that, I spent 3 years there. And WashU was a little bit too ivory tower for me. Plus, there were just incredible opportunities here in Kansas City. But I have a story to tell later on about my time in St. Louis that explains a lot of why advocacy and equity in particular are very important topics to me. So like Dr. Templeton, I really appreciate that we're having this conversation. I think as surgeons, we have much more in common than we have that divides us between specialties. And so there are so many opportunities for us to kind of join forces and advocate on behalf of surgical patients and on behalf of surgeons.
Okay, so our first kind of question is going into our theme for today. What motivated you to kind of seek a bigger role and want to be involved in leading advocacy?
I think that's a great question. You know, in med school and residency, I must say that I didn't really think much about it because you're just so swamped with everything that you're trying to learn. But the minute I got out and joined my practice, I joined a private practice in Lawrence. And initially, I thought, oh, I'm just going to start practicing and see patients, and that's all I'm going to do. But over time, I realized that if you're not advocating for yourself and your patients, then you can't complain about it if there's stuff that happens that you don't like. So that was a big motivator for me to start to get involved. And so I started kind of at a local level in the hospital and things, and just kind of started becoming as involved as I could on different committees and various things like that. Subsequently, have moved up to the chief of surgery over there. And because of that, it's just allowed me to, again, advocate on behalf of the patients, as well as the surgeons in my practice, and various things like that. Secondarily, throughout the process, and actually, this was something that came from residency. We were always encouraged to go to the Kansas Orthopedic Society meetings. And so I saw the value of that as a resident. And then I just kept going to the annual meetings afterwards. And because of that, got involved in the leadership tract on the Kansas Orthopedic Society. And again, it's on a bigger level, it's the same concept of, if you aren't at the table, you're not going to be able to have any say in any decisions. And I haven't gotten into any national advocacy on a large role yet, but hopefully over time, being involved with the academy, the AOS and things like that will help. But again, I think that's the biggest thing is, you know, if you aren't involved in the decision-making process, you can't complain about things that happen. So anyways, that's kind of my story.
Dr. Templeton.
I would have similar comments. First of all, I grew up in a political family, and an uncle that worked at HHS in Washington, so spent many summers in Washington, D.C. So I grew up as a political animal and love it. But from a practice, but I never thought that was something I personally would be engaged in until I was in practice. And similar to what you just heard, you see issues that arise, and after a while you think, why isn't anybody fixing this? Why isn't anybody addressing this? And actually what you find is that the more people who are around who see a problem, actually the less likely somebody is to do something. either because they're afraid to speak up, or they think there's so many people that see a problem that certainly if it was a real problem, somebody's going to speak up at some point. And what you don't realize is that everybody's thinking the same thing and they're kind of waiting for somebody to say something. And so you eventually get to the point, it's like, this is a problem, we got to fix this. And so once you do that and you speak up and you realize that you have people that feel the same way and you've got support, it's easy then to speak up the next time and the next time and the next time. And so you become much more comfortable doing that. And so then you get more involved because people realize that you actually do have a voice, you do have a point of view. And so you move further up in the food chain in terms of the people that are asking you to do things. So you start off with advocating for your patient. As much as we all hate the good old prior authorization, that is a form of advocacy for our patients. And then you look at improving things from a department or a hospital system level. You look at improving things from a medical school level. And then you move on to statewide. And eventually, if you have a consistent message, you find yourself being asked or invited to do things at a national level. So I've kind of worked my way from patient advocacy to presidency of Kansas Orthopedic Society, to presidency of the Mid-Central States, which is one of the 5 regional orthopedic societies, to presidency of RJOS and AMWA and the USBJI, to now being on advisory committees for the NIH. But it's always, but it's being comfortable and having that voice and realizing that if you don't speak up, likely nobody else is either. And so you've got to be the one that wants to inspire change and affect change.
So I always tell people when kind of going back to my story that, you know, you hear where I grew up, where I lived and all that. And, you know, so Naples, Florida, there's not a lot of bad trauma or violence there. It's a pretty pedestrian community in terms of that. It's very wealthy. I personally grew up the son of a general contractor, worked on construction sites, so that wasn't really my upbringing. But that environment was a pretty sheltered one. Go from there to college, go from there to medical school. Nobody's really talking about things like that. Although I would say, as a medical student, I was very interested in. There was a big movement called Healthcare for All when I was a medical student. And the American Medical Student Association was really pushing that forward. And so I would say, you know, at that point, I thought it was kind of ridiculous that somebody could come into the hospital and you could potentially deny them care that they needed or that would benefit their life on the basis of ability to pay. But you talk to my medical school classmates, and that was not necessarily the prevailing theme for everyone. There were people who said, you know, healthcare is a right, not a privilege. That never sat well with me. I would say surgical residency, I kind of disappear again for a while. You start to get into making sure that you're technically good at what you do, that you're good at taking care of patients. But the one thing that sort of stayed with me, and one thing that has influenced me to this day, is I remember I used to get very frustrated as a junior surgical resident, as an intern junior surgical resident, going around on the trauma service. And you know, again, my family is a kind of blue collar family, pretty rowdy group, to be honest. And so I saw shades of my family and the trauma patients. And, you know, we'd go around and people would, you know, the way that they would talk about those patients, about the trauma patients, just irritated me to no end. And so as soon as I got in a position, you know, where I was a little more senior as a resident, you know, we put a stop to that. Somebody make an offhand comment about a trauma patient, and I'd say, we don't talk about patients like that. You know, would you talk about an oncology patient that way? Is that really how you feel about taking care of this person? So it really troubled me that we sort of treated people that way. But again, I trained in Gainesville, Florida, not a particularly violent community, college town, and so very different from what I ultimately experienced in San Diego. A little more sort of violent crime and trauma, just a bigger community overall. But California has pretty strict gun laws. Tend not to see a lot of shootings in California, at least in San Diego County. So when I get to St. Louis, Barnes Jewish Hospital, 3,300 traumas a year, 27% penetrating trauma. And so day in, day out, I'm responding to trauma activations in my first year out as an attending, and it's people shot. I had a 24-hour call I saw 21 people shot in 24 hours. And so initially, again, much like in training, at first you want to make sure you're good at physically taking care of patients. But after a while, if you're any bit thoughtful about it, you start to ask yourself, why is that? Why do I see 21 gunshot victims in 24 hours at Barnes Jewish Hospital? Why are they predominantly Black? Why do they predominantly come from certain neighborhoods? And so looking at these things, and then you start to ask questions, or I started to ask questions about how the community was structured, and about equity, and about the things that sort of are behind the story of why someone comes in as the victim of gun violence. And from there, I was sort of formulating ideas. My wife is an urban planner, and so we had a lot of discussions. And to me, I would come up with some idea that I thought was novel about how the community was structured, and she'd go, "That's like 20-year-old urban planning data that can tell you about that." But in the trauma community, talking about those sorts of things was fairly new. What I found is that much like doctors Goodyear and Templeton, is that sometimes you kind of feel like you're the only one maybe thinking about an issue. And it's you think, well, I don't know if I can really if I've got the juice to get traction in discussing something like this. So for me, what changed in a big way was I happened to have a couple of friends who we were talking about this at a meeting one time, and then from there everybody knew somebody else who also was interested in talking a little bit more about it. So we started to kind of develop a critical mass. And so through the Eastern Association for the Surgery of Trauma, we developed a group that looks at surgical equity and looks at health disparities in trauma patients. We were able to push, I would say the American College of Surgeons is, like a lot of large surgical organizations, tends to be fairly conservative, slow to move on issues, on sort of social issues. However, we were able to get the Committee on Trauma to actually form a committee within the Committee on Trauma on addressing structural issues associated with violence. And so now that is influencing things that are going into trauma center verifications and things like that. And so I hear echoes of all of that in Dr. Goodyear and Templeton's stories about, you start to get involved, you start to volunteer, you start to get invited to talk about things, and then all of a sudden your voice is a lot louder in the community than it used to be. People are like, oh yeah, Winfield is very interested in equity and gun violence and health disparities related to that. And so when those topics come up, now the American College of Surgeons will reach out and say, hey, we're having this panel, or things like that. And you have opportunities then to influence the way that things are going in the field. And hopefully on the other side of that is changing the way that we're taking care of patients, getting out into the community, which is something that's very important to us here at KU. And trying to sort of lead other people down that path so that you ultimately influence what was the problem in the first place, which was, why do I keep seeing these people coming in shot, and how can we address that issue?
And I would echo Dr. Winfield's comments. Those were great. And I think a lot of times when you're younger and you're thinking about advocacy, it's like, so going into advocacy and I'm going to go to Congress and get things fixed. That's not really how it works. It is finding an issue. And similar to Dr. Winfield, I remember when I first got involved with this, we were still in the middle of the night when we were fixing hip fractures in the middle of the night. I was wondering why we were on the umpteenth for low impact hip fracture that we were fixing on someone. I thought, why aren't we addressing this further upstream? Why aren't we treating people's osteoporosis, or even better yet, preventing osteoporosis, rather than just waiting until they fall and break something and then we fix it? Because yes, we can go ahead and fix it, but patients that have low impact hip fractures have a high mortality. It's an extremely expensive condition to fix, and not all that expensive to try to prevent. And that was sort of similar to Dr. Winfield's aha moment with the gunshot call. Mine was with the hip fractures. It's like, why aren't we doing something further upstream? And then again, you talk to other people, you find people that are interested in the same topic, and you realize that maybe there are opportunities that haven't been addressed yet. And so that's really how you get involved with this, is you're going to have an aha moment, frequently patient related, that you say, why hasn't somebody done something?
Well, and I'd like to say something from a standpoint of, Dr. Templeton's talking about the osteoporosis and just an example of how that has affected, even places like in Lawrence, we didn't have a fragility fracture program. And since I've joined because of her advocacy for the osteoporosis, and I remember the Own the Bone program that the Academy, which she was very involved in, kind of getting going and that sort of thing when I was in residency. And we've utilized that program to help build a fragility fracture program in our small community hospital. So, yes, the advocacy will help the big places like the KU Mets of the world, the St. Louis, the Barnes Jewish and St. Louis and things like that, but it will help, it'll filter down to the small community hospitals as well, which is where we're at. Another thing I'd like to say is it always requires a little bit more time than you think it's going to require, and it's never as it's not like you're going to get a trophy for it or anything like that. So, we're all very driven people. We like to see results very quickly, and a lot of times it's not that way. And so it just requires continually pushing the rock uphill. And sometimes it gets a little bit challenging, and sometimes you're looking around saying, why isn't anyone pushing with me? And you just kind of gotta just keep going. So that's something to think about too.
Awesome. We appreciate those comments, and kind of going off what you guys just mentioned, the next talking point kind of goes around, you all come from a diversity of different experiences, and you work currently in different environments as well. When you notice these problems, when you notice something that you feel like you need to speak up or make change, whether it be, so some of you are academic, some of you community and private, can you say, like, what are the steps that you do in your own setting that you work in?
I can start again. So I work at LMH Health and Ortho Kansas. Started with we were private practice when I first started, and subsequently between when I started and now we have been acquired by the hospital, so we're hospital employed now. So initially when I started, it was like, well, we're private practice. If you notice a problem, you kind of you figure out whether it's cost effective to deal with it, and you do it. Now, being part of the hospital, it has actually helped us quite a bit become a little bit more effective in creating change at the hospital itself. And, the biggest thing, for instance, so I'm just going to draw from my experiences, there was no total joint program when I got to LMH. There was plenty of total joints being done, but there was no program. And so the first thing I did when I got there was like, hey, and I can't remember who I talked to, but it was someone in administration. I said, I'd like to get a total joint program started. And, someone was like, oh, that sounds like a great idea. So just as everyone has alluded to, if you find an issue, sometimes you just have to tell somebody about the issue, and then because maybe someone else didn't see it as an issue or that sort of thing. And sometimes it's just identifying it. But anyway, so then you get the ball rolling a little bit. And again, sometimes it requires a lot of upfront work to kind of get things rolling. But then eventually over the years, now we have a huge team, and we have a musculoskeletal service line that helps manage the total joint program. And we just got accredited by the Joint Commission for one of two places in the state that has the gold distinction from the Total Joint Commission, or from the Joint Commission. So, no total joint program to now accredited by Joint Commission, which, that's a period, it took, 5 years, but, we did it. So again, it's just, it's not instant gratification, that's for sure. I think that's one of the big things. And when you get to a place like this, these guys will talk to you about that. It might take even a little bit longer with all the bureaucracy you have to fight through sometimes. So small community hospital, maybe a little less bureaucracy. I mean, you know the administration a little bit more personally, things like that. I mean, I think that's a value for where I'm at. So.
Dr. Templeton.
So if you see a problem and you want to affect change, the first thing to remember is you don't have to have a title to do that. So just because you're not president or chair of X, Y, or Z doesn't mean that you can't affect change. And actually the vast majority of change occurs from people that don't carry titles. If you're going to wait for somebody to carries the title to affect change, there's not going to be a lot that happens because they don't always see what's going on at the ground level. So if you see a problem, identify the problem, ideally come up with some initial solutions, which may be awesome and they may be completely wrong, but it's at least a place to start, and then start networking. Reach out to those whom you know and reach out to the people that they know, or go online, do your research, find out who might be interested, and just start talking about what you see as an issue, what you see maybe are potential solutions, and can you start sharing ideas, and then start reaching out and figure out what you do with it. So when I was dealing with the issues with osteoporosis, for example, I did some networking. We did put together an education program that we were giving to patients at KU. I then put an education program together for all of the Komen Race for the Cures, since there's a high rate of osteoporosis among young women with breast cancer. So I was loading up the pamphlets, and as Dr. Goodyear said, there's not a lot of glory in this most of the time. So loading up the pamphlets in my backpack and flying around the country and going to the races and handing out flyers to anybody that would take one. And eventually network through that with someone with the US Bone and Joint Initiative. And then they were starting to do some public education on trauma and arthritis. I said, why aren't you doing public education on bone health and osteoporosis? And so that got into then working with them and developing a program for that. But it's reaching out, it's networking. Again, it's not waiting for somebody else to speak up, and especially not waiting for somebody with the title to speak up, because they may not see what the issues are at the ground level. Just take responsibility for it and find your supporters.
Yeah, that would be my message too. And I will just add, you're going to knock on the wrong doors sometimes when you start. You may find people who are not interested in what you came to talk about. But when I was in St. Louis, I actually got really lucky in terms of starting to address the issues of structural violence and how they relate to gun violence. And I was reading an editorial in the newspaper that was written by two WashU professors, one in the School of Law and the other in the School of Social Work. And they had come together to talk about how urban planning history within the city of St. Louis had led to actual physical barriers being erected between different portions of the community. And so I reached out to him and I said, hey, I read your editorial, and here's what I'm seeing from a trauma standpoint, because their letter had nothing to do with trauma. And so I reached out to him. So we then applied for funds through WashU, and that's one of the nice things about an academic environment is that there were usually little opportunities out there to get funds to get people together. And so we were able to convene a group, this really kind of interesting group of people, to just start talking about what the issues were related to structural violence in St. Louis. And so we have people from all these different fields. We had a guy who's an art professor and talking about the relationship of art and its effect on the community. Again, school of law, school of social work, just people from all over the spectrum. And so that was one thing that we were able to do there was, and I think, for this particular issue, I think a lot of it was and remains having the conversations with people, conversations that they've never really had or haven't really thought about in a particular way. At KU, one of the interesting things about tackling this issue in particular is that in the end, I say gun violence, but the reality is that we see violence from a lot of different means, blunt injuries and stabbings and that. One thing about KU in particular, and I'm sure WashU has to deal with a little bit of this as well, but KU is very sensitive to anything the legislature might perceive as being politically motivated. And so as a result, when I've come to people at KU and talked about addressing gun violence, they get very anxious about that because they're concerned that that may lead to someone not voting for funds for KU down the line and things like that. And so we've had to sort of adopt a very different approach, and that is a lot of places are they're really beating the drum. You have to ban guns. And, that's a non-starter here, even if I believe that was the right thing to do. So here, what we had to really focus on, again, were community features and structural issues related to the end result of violence. And so we really dropped the notion of addressing gun violence specifically and just started talking about violence. And, I talked to anybody who'd listen about these things on rounds, when we sat in trauma M&M, it really didn't matter, I'd bring it up. And as I said, I sort of made friends around the trauma community, just talking with people, so you get different ideas. So then after a while, somebody said, well, why don't you give a talk about this? And so I gave a few talks around the KU campus to get people on, just sort of thinking about it and having these conversations. Ultimately, we then sought out some funds from the Bohan Society, and we organized a symposium. And the whole motivation behind that, we brought in speakers from around the country who were experts on firearm injuries and firearm violence in particular. But the whole goal of that was really not to bring in a bunch of speakers, but to get people from the community here in Kansas City who were interested in that. So, we got people from Aim for Peace, we got people from law enforcement, we got people from clergy, and all these different groups that are all working separately to try and address the issue of violence, all these different ways. And by organizing the symposium, courtesy of KU's funds, we were able to get all these people in the room, back when we could get a big group of people in a room, and get them all in one place and talking about this. And so what that has ultimately led to in our community is that caught the attention of some people on the main KU campus in Lawrence, who run a youth violence prevention effort in Wyandotte County. And so we started to partner with them, and they just announced here in the past couple of weeks that we were awarded a Centers for Disease Control Youth Violence Prevention Center grant for Kansas City. And so that's going to allow us now to move beyond Wyandotte County to bring in Truman Medical Center and Research, Jackson County, places where we're seeing violence across our community, bring in all these different community partners courtesy of grant funding to enhance our youth violence prevention. We're one of only 5 centers that were funded by the CDC for this. So it's really exciting in that, again, it's taken years and a lot of just, talking with people to get to this point. But I know that this is going to infuse some energy and, again, some dollars that will help us address the issue of youth violence in Kansas City. And again, it all comes back to that issue, sitting in St. Louis saying, why is this happening over and over and over again? And talking to enough people that where eventually something starts to move.
Awesome. So we're going to open it up. We have some prepared questions that people submitted ahead of time, but we want to open it up. Does anyone have any questions, either online or in person? Okay, we'll take some time to think of some questions, but in the meantime, here's our first submitted question. How do you work on not compromising personal beliefs when social justice problems arise within the work environment?
I'll take that first and just say, I think in the end, you have to do it what's right. That's easy for me to say. I'm in a senior position at this point, and and if somebody says something, I can basically put a stop to it. And I realize that when you're in a medical student position, you're in a bit more of a vulnerable spot where you have the chance, if you decide to speak up about something and you're disagreed with by the person who's evaluating, that can have some pretty harsh consequences. In the end, I do think there are ways to work around that. I think you can, there are lots of strategies to sort of redirect people in terms of comments that are made or actions that are taken to point out that what's being done is not acceptable. And so short answer, I don't think you have to compromise your beliefs. If you think something's important, I think you have every right to speak up and say something about it. I think, again, your approach may be different depending on the stage that you're at in your career, but there's no reason to give up on it. These are important topics, and they're certainly not going anywhere.
Well, and I do think, and maybe Dr. Templeton will talk about this a little bit, but residency programs, I think, have become very sensitive to training and to, you know, you hear these stories about back in the old days, we worked 1,000 hours and it was all men and, all of these crazy stories. And I think it's, and Dr. Templeton can probably speak to this more intelligently than I can, but I think that there has been a change in a positive way to allow, just what Dr. Winfield is saying, if you believe something, your attending physicians, there's ways to address that, or in the people in the senior levels, there's ways to do it through the residency program and the other kind of residency overseeing boards and things like that. So I would reiterate that if you think that something's not right, you need to speak up, and it's always easier said than done, right? And there's always a good way to do it and a bad way to do it. But if you treat people right, I think you'll generally do well.
I would agree with all of that. You just need to be very clear on what your beliefs are. Sometimes it's not clear, and you just need to take some time to think and figure out what your beliefs are, but you never want to compromise those. But if someone is confronting you and is belittling your beliefs or is contradicting your beliefs, all depends on the setting and how you respond, and also understanding why they're doing it. They may just be doing it to try to get a response from you, and that response isn't worth it. So just redirect and move on. And you're less likely, at least in my experience, to find that being an issue dealing with other physicians and other healthcare professionals. Where you're more likely to have issues is in dealing with patients and families. And as a woman, I'm going to face it even more often than typically men, because especially if you have a male patient, they feel that they can confront a woman and that she's not going to back down, or maybe trying to see if she will back down. It's not worth getting into an argument. You've got to remember why you're there and what you're doing. And so if there's somebody that's trying to confront your beliefs or disavow or put down your beliefs, just deflect, move on, and focus on what you're doing. Unless it's somebody that's in a position to actually have a significant impact on what it is that you're trying to accomplish, it is not worth the argument. It's tough. I would recommend talking to somebody afterwards, but just redirect the conversation and move on.
I have a question. And first of all, sorry I can't be there in person tonight. I'm out doing a rotation outside of Kansas City, a couple hours away. So my question for Dr. Goodyear, and I'd certainly love other perspectives as well, but I think coming into medical school, I had what I now understand to be a false misconception that only academic physicians or physicians practicing in academic medical centers were involved in advocacy. So can you talk a little bit about just any like nuances that exist, not being in an academic center, and potentially how maybe there are unique ways that as a physician that's not at KU Med or another academic medical center, that you might have some maybe flexibility or other components of your job with advocacy?
Well, the first thing I would say is everyone is at some point in their career in an academic medical center, from a standpoint of you have a training facility that you're going to be at. And that's where you network with the physicians that train you, quite frankly. And I've utilized those physicians a lot. I've talked to Dr. Templeton and Dr. Toby at various times throughout the last several years. They've obviously been very involved in advocacy. And so just because you're not at an academic center does not mean you don't have access to an academic center. And so I think that's a valuable piece of information. Secondarily, I think that especially when you get involved at the state, I would say start at the local level. So if you start in your own hospital and slowly kind of work your way up and then get to the state level. For instance, the Kansas Orthopedic Society, again, advocacy takes time, and going to the Kansas Orthopedic Society meetings takes time out of practice. And so there doesn't tend to be a lot of people that actually attend the meetings. And so if people see that you actually go, then you're going to be tabbed as the next president, which is exactly what happened to me. Whether good or bad, I don't know, but that's the way it works sometimes. If you show up, you're gonna be there, and you're gonna be. And so whether you're in academics or not, if you show up, you're gonna be there, and you're gonna be at the table. So that's the thing I would say. Basically, is just show up, and then eventually it kind of works its way out.
And most of the people that are doing a lot of the advocacy are not in academics, but it depends on advocacy what. If you're looking at patient-centered advocacy, et cetera, that's mostly done by people not in academics. If you're looking at research, that's different. But at least in my experience, at least from an orthopedic standpoint, most of the people out there that are working on these issues at either a local or national level are not in academic practice.
Yeah, when I think of, so within the structure of the American College of Surgeons, which by the way is open to all specialties, but one of the most effective advocates I've seen over the course of my career is Tyler Hughes. Dr. Hughes, I don't know if anyone said to rotate out in Salina or anything like that, but he has a faculty appointment now, but he started in sort of a large group practice in Dallas, but then relocated his family to McPherson a few years in because he really wanted better connections with patients. And so he got out there and he saw what being a rural private practice general surgeon was like, sort of a few years into his career. And he realized that there was not a ton of support for what he was doing or how, or the patients that he was treating. And that guy has made his career mission to improve the conditions for rural surgeons. And so I've seen him, he's now on the board of regents for the American College of Surgeons, but that's been a whole career of just like all of these stories. You start out by talking to people about it. Hey, Tyler Hughes shows up at the American College of Surgeons, says, I'm a rural private practice surgeon in McPherson, Kansas. And, these are things that I'm seeing, and, the people at the academic center, they don't have to deal with these same issues, and there's no avenue for that within the American College. So, then he was able eventually to have a whole advisory council created within the American College. There are now rural surgery specific educational efforts, rural surgery patient education efforts. All these things started with Tyler Hughes showing up at a meeting and saying, hey, this is what I'm seeing in my practice, and this is how it's impacting me, and it's how it's impacting my patients. We got to talk about this. So you do not have to be in an academic center to push these things forward. I think you just need to be passionate about a topic, and that passion shines through when you come in and you talk to people about it. They're going to hear it, and they're going to listen to you intently because they can hear it in voice, they can see it in your actions.
The important thing to remember is that one of the recent presidents of the American Medical Association is Andy Gurman, who is an orthopedic hand surgeon in Altoona, Pennsylvania. He's in a small private practice, and yet because of his passion and his knowledge, especially of a lot of Medicare-related issues, rose to presidency of the AMA. So that's a non-academician that kind of rose to the tops of the ranks, at least in that venue.
Well, and the current AOS president is Daniel Guy, who is in a private practice in kind of halfway rural Georgia. So, again, and he's the president of our biggest academy. So, yeah, I would echo what everyone said. It's you don't have to be an academic to be an advocate for sure. So,
we have a question from the chat from Eva. How have you seen a shift in patient advocacy for young female athletes in the orthopedic community following the USA Gymnastics trial?
I will start with that. And it's a great question. I would say personally, it's been less of something that's orthopedic focused than really something that's been taken on by the entire medical and especially medical regulatory community. So the Federation of State Medical Boards came out with the position paper on physician misconduct, which if you read it is talking solely about inappropriate behavior and what are actually called boundary violations with patients and family members. That came out after the whole Larry Nassar thing. And I did some work with them on that. The Greenwall Group, which is a think tank actually at Washington University, put together a group of us last year to come up with guiding principles for state medical boards in dealing with people accused of sexual harassment And I'm working with our state medical board on coming up with some guidelines and regulations. And so I think it's less to do with just orthopedics and something that is really reverberated around the medical community in general. And again, the medical regulatory community, because we know that the vast majority of people that are victims do not report because they think they're afraid of repercussions. They're afraid that nothing happens. And if you look at the data, they're right, not much happens. And so the regulatory community is figuring out then how do we try to get our arms around this and make sure that those that have committed egregious behavior actually face consequences. But my push is it's important that we address this. It's critically important that we deal with physicians and other healthcare professionals who cross the boundary, have inappropriate interactions with patients and family members. But what we need to remember is that that usually isn't where things stop. And we need to also look at inappropriate behavior with students, trainees, and other healthcare professionals and other physicians. And so that's part of the things that I'm doing through the American Medical Women's Association, is trying to continue the conversation about boundary violations with patients and family members, but then expand that to make sure that students, trainees, and physicians are also protected from this behavior. So I think it's a great question. It's just that it's the response has been less specific about just athletes and just orthopedics.
I don't know if I have anything to add other than it kind of goes back to the first question that was asked, like, what if something goes against your personal beliefs? How do you handle that? Well, I think, unfortunately, in this situation that we're discussing, it got too far and no one spoke up. And then finally, some of the victims came out and started talking about it. But maybe it could have been preventable or much less dramatic if somebody would have spoken up early on. So I think that does speak to the value of advocating for patients and just being, doing the right thing, thinking about your personal beliefs and going forward with that. So.
Yeah, totally agree. Nothing significant to add to that.
Do we have any questions from anyone else in the room right now?
And those sorts of situations can be challenging, again, because people are afraid to report, they're afraid to get involved because they're afraid of negative consequences to them, and that can be intimidating. That's where you reach out for support, and you don't have to go it alone. If there's an issue that does violate your personal beliefs, an issue that you think is wrong, you think something needs to be done, there's always going to be a way to bring that to someone's attention, but you need to make sure that you've got backup and support, because just doing
Well, and I'll add to, at least with my experience, every single attending physician that I ever worked with was always very receptive to anything. Now, again, you might run into some that maybe aren't, but I'm sure in every department, there's some that are willing to help you. To Dr. Templeton's point, don't go it alone, ask for support. Every one of these physicians has been in the same situation you have, because they've all been in training before. And so, some are better probably at understanding than others, but definitely reach out. And I know if you ever need anything, any advice, send me an email. I mean, I'll be happy to help you, that sort of thing. So.
Yeah, that's exactly what I was gonna say, just to toss in, being a small person reporting something can be very scary. So get somebody on your side that's not so small. And, at this institution, we've got Kim Templeton. If there's an issue in the orthopedics, you got me to go to. And as you go out, you're going to find people that have a reputation for being approachable and for caring about these kind of issues. So identify that person, and then you have somebody that you can ally with. And then you don't have to have that pressure of someone is, compromising one of your beliefs in the moment. Now, obviously, if it's dangerous, you say something, but if it's not something that's imminently dangerous, you have that ability to step back from the situation, process it, get your ally involved, and then address the situation from a better position.
We have a question.
I think a really good comment was made earlier about you can't affect change if you don't sit at the table. And as medical students, we're pretty far down on like the pecking order of things. But from your perspectives, where would you suggest, which tables would you suggest medical students start sitting at to be involved in productive conversations and more conversations and putting themselves in those positions to help influence training and, you know, what we can practice from our level of experience. So where would you advise people to start if they want to start interfacing with change in surgery, orthopedics, and medicine in general?
I would say first identify what challenges or problems interest you. What is your passion and what do you see that needs to be fixed or addressed? That's going to help a lot, because then you can get your advocates out there to target you to the right organization or the right group, or maybe the issue you're finding doesn't have a group and you want to start your own group. That's awesome. Get some help doing that, but find what your issues are. If you're not sure what your issues are, and I have no interest in this other than it's a group with which I work. The AMA has an extremely active medical student section and resident and fellow section. Those are great places to get your feet wet in advocacy and to find out what the issues are, at least from a local and a national level, to see if there's a place where you want to jump in if you don't already have your own issue. If you've got your own issue that you want to address, again, it's finding the right group and the right people, and advisors can help you with that.
Well, and I would echo the fact that every specialty organization has med student / resident resources, and potentially, for instance, the AOS I know has some residency fellowships and things like that you can get involved in. As a med student, I'm so far removed, it's so hard for me to know what, but every class has their leadership, their president and their secretary, treasurer, all of those things. So start at things like that, if you have that, or quite frankly, the social committee chair, it's just getting used to being a leader and speaking up, I think, is probably the thing. And quite frankly, in medical school, I really didn't do any of that. And, now I'm doing this type of stuff. So it's not like you have to be doing something, but start thinking about it, and then it slowly kind of gets there.
Yeah, I think, again, it gets back to what are you passionate about? What is it that you want to do? And again, there are a lot of different organizations that could take you in different directions as far as that goes. I will put in a plug for, if you're interested in social justice and equity for surgical patients, we in the last couple of years brought a group called Socially Responsible Surgery to KU. So this was an effort that started at the Boston Medical Center, and has branched out to first UC Davis. We were the third site in the country to have a socially responsible surgery group. It's open to surgeons in all disciplines. It's open to residents in all disciplines, surgical disciplines, I should say. I don't think I'd turn down an internist, but it is socially responsible surgery after all. And to medical students. And in fact, while the Boston Medical Center's effort really started with residents, ours started with Tara Hill, saying, I really want to get this up and running at KU. And anybody who's met Tara or worked with Tara, she's super passionate about it. I see Aaron Venus is on the Zoom. He's our current president of the Socially Responsible Surgery. And this is an opportunity to get involved in advocacy, community outreach. You can do research related to surgical equity. So if that's something that you're passionate about, please, by all means, you can go on the beat and join us for that. But again, the rest, no matter what you're interested in, there's a group for you. And sometimes it is going to your broad society, like the American College of Surgeons for me, or the Academy of Orthopedic Surgery, and figuring out what all is going on and hearing about it so that you can say, yeah, you know what, that really resonates with me. And so I'm going to head down that path and see what I can do to help in that area. But I would strongly encourage early involvement. The earlier you start getting a foot in, the more you know what the issues are, you start to meet people and network. You never know when those connections are going to be beneficial to you down the line once you find that area that you're truly passionate about making a change.
So we do have one more question we want to touch on before I ask it. Aaron, we did invite you. Do you want to share any of the opportunities that you wanted to discuss with socially responsible surgery?
Yeah, absolutely. Like Dr. Winfield said, he just gave a great kind of overview or introduction, but one of our branches actually is a advocacy branch. So if you're looking to become active in advocacy or any of our other branches, always reach out and I will drop our email so you can email or message on the beat, whatever you'd like. We have Twitter and social media I can put in here as well. And I guess one more plug, early next semester, we'll be sending out applications for leadership positions. So if you're interested, feel free to apply and we'd love to have you aboard.
Awesome. Thank you for that.
And I would say too, if there is something about which you're passionate and you do your research online and you find somebody who's been working in that area, don't be afraid to reach out to them. Send them an email. The worst is going to happen is they don't respond. But the best is going to happen is you might find somebody that can help you. Like I spent last night talking to a student at University of Georgia who found out that I'm interested in physician reentry. She hadn't heard about it before. She'd like to get involved from an advocacy perspective. So we discussed an advocacy plan. I don't know how she got my email contact. I don't care, but she found me. So don't be afraid to reach out, because if people are out there who are passionate, who are working in a field, we love nothing more than for somebody else to contact us who wants to join in and join the party and try to affect change.
So does anyone have any specific question they want to ask real quick? Okay. You have one? Oh, sorry. The last one we had, I think this is an important one. It's a good one to end on. It was from pre-submitted, and it has to do with sometimes there's the worry and the risk of being too much of an advocate. And there's the worry is that sometimes if someone who has a different opinion than you might, the word like quote unquote cancel you, or maybe not let you get into residency, or won't hire you for a job later down the line. How do residency programs approach this when they're like looking at applicants and they see that someone is a really big advocate for a certain thing? And is this something that you've encountered in your workplaces?
I don't know that I can answer the residency question, but I do think that being an advocate does mean that you have to have good communication skills. You need to be able to get along with others. Okay. If you can disagree with people, I think that's absolutely a good thing, because if everyone just thought the same thing, then we're not in a very good spot. That's what makes this country great, right? Is we have differing opinions. We can all talk about them and air those opinions and things like that. And trying to figure out a way to communicate with people in a productive way, I think is a very valuable skill. Over time, I think you develop it and you learn how to communicate with other professionals and things like that. And for the most part, I do think, to Dr. Templeton's point earlier, most folks in a professional situation are going to treat you like a professional, and you should offer them the same courtesy as well. And so I think that from a canceling perspective or something like that, I don't know that that's going to happen often, but maybe Dr. Templeton can talk about residency programs and how they select folks at this point. But anyway.
I mean, so there are some programs are different. Some programs will troll social media sites of applicants. I don't. I would say most programs don't. Some do, most don't. I'm not really interested in what people are putting out on their social media sites. But if you're an advocate for something, as long as it's something that's like not too far out of field, I don't think it's going to interfere with your ability to be selected for a residency program. As long as you're not spending 100% of your time doing the advocacy and you're actually getting the rest of your stuff done that you need to do, as long as it's not going to take too much time away from your training program. And also, as long as it's not too out there in terms of your viewpoint, I don't think it's going to interfere. I don't think people are going to see that as a negative. As I just mentioned, that being an advocate means you're a good communicator. What do we look for in a residency program? People that are good communicators. So it's actually a good skill to have. I would just be cautious in how you do that. You always want to be professional. You've got to realize that no matter what you do, you're held to a higher standard than everyone else. So if you're advocating, do it professionally. And as long as you're doing that, I don't see how it's going to get you in trouble.
I'll just say that, again, some of these comments are easier having already gone through all of this. But I do know that when I was going through residency, one of the approaches that I took at that time was to say, you know, they're evaluating me to see if I'm a fit in their program, but I'm evaluating them to see if I'm a fit in their program. And I think that's important to keep in mind. And, you know, if you're coming in and again, you're professional, you communicated well, you've shown consistent involvement in something, or you're passionate about it, and you know, you interview at a place and they go, why in the world would you do that? That's probably not your place or the place you want to spend the next 5 years of your life, right? I mean, if it's truly important to you, that's going to be tough sledding for a long time. And so, you know, I think that's an important thing to remember too, is it is a match. And again, I recognize you have to get a slot and you have to, you know, in order to advance and things are very competitive in orthopedics and even general surgery now. But again, it's a match. And if someone really can't hear you out, if you've done a good job conveying your message, then you know you sort of let them go and you move on to some place that is going to be respectful of what you do or interested in what you do, and again look for that ideal fit.
The only thing I would say to be cautious in advocacy as a student is make sure that it's somewhat focused. Where I have concerns is if I'm reading an application and a student will list 10 or 15 different volunteer/advocacy things in which they were involved, none of which seem to connect. That always makes me worried that somebody's doing something just because it's an opportunity and then they do that, then they move on to the next thing. So if you're going to be involved in these things, try to have some sort of consistent theme or focus or some way showing how they connect. You're better off taking a deeper dive and getting more involved in affecting change, more change on a few things than becoming superficially involved in a bunch of things.
Awesome. Well, thank you again. We really appreciate all of you for your comments today. I know we've taken a little over an hour of your time. So just before we kind of close it off, does anyone have any closing remarks they'd like to add?
I'll just say thanks. Thanks again. You know, this is incredibly important. I'm glad that you're interested in advocacy. Glad you're interested in surgical careers, even if it's not mine. That's okay. And so I really appreciate y'all having this discussion and for having me involved in it. So thank you.
I'd say the same thing. Thanks so much for having me involved. I appreciate it. And I'm thrilled that you guys are interested in advocacy because as surgeons, you have a powerful voice out there.
I'd echo everything. Also, I am happy to have anyone, if they want to come to Lawrence and see what a community hospital is like, community practice, happy to do that, arrange that. I brought a couple cards of both myself and our practice manager. So I'm happy to stick around tonight and answer any other kind of other questions as well, unrelated to advocacy, but just practice management, things like that if needed too. So.
Well, thank you again. Thank you to everyone for tuning in virtually and in person. We'll have some people stick around if you have any further questions, but that's it for tonight. Thank you.
Absolutely.